a preview of, okay. So I just want to acknowledge that we're living and working on the traditional territory of the Musqueam, Salish, and Tsleil-Waututh Waututh nations, and some of you may be elsewhere in the province. So we're grateful to be able to share this land and to use its resources. I'd like to now turn to the learning objectives. Next slide. Over the course of this conversation, we're going to you'll be able to describe a 6-factor framework for implementation of change. And the watchwords here are implementation of change. That's really what Allan and I are most interested in, is actually being able to apply a research to achieve change in this context in the healthcare system. We'll pay particular attention to values-driven leaders. And it's interesting, this got renamed in your program as value-based leadership, but it's actually values-based leadership. It's about values. And then, as I said, we'll talk about case examples. Next slide, please. So to begin with, I'd like to just remind you of the complexity of the healthcare system. And in our paper, we make reference to the fact you can view this as like the story of the elephant described by 5 blind men. And each of them that touches the elephant in a different place thinks that the part that that person feels represents the elephant as a whole. And that's in many ways how people behave with respect to the healthcare system. They think they know it because of the little piece in which they interact, but it's actually quite different from that. Next, please. So to understand how better to bring together research, knowledge translation, and policy, and the people that are trying to implement in each of those areas, we need to understand healthcare as a complex adaptive system. And we're not going to describe the characteristics of complex adaptive systems. I'm just going to remind you that it's nonlinear, that A does not lead to B, that sometimes A leads to X, and sometimes X goes back to P, and many things are happening. There are a lot of moving parts within a complex adaptive system. But in spite of its complexity, the thing that's reassuring is that there are simple rules that apply that can help you to find your way through complex systems and be able to achieve your goals. In the context of our conversation this morning, what we want to emphasize is that innovation and change are essential. As I said before, that's our focus. And what we want to figure out is how do we do better than we've currently done, because we certainly have had our problems with each of us within our organizations and our experiences with trying to make change. And when anxiety goes up, we tend to revert to earlier ways of functioning and think that we can be linear. And you see people reverting to command and control, trying to tell people what to do and make things happen in that way. And it's our thesis that that's not going to be very effective. Next, please. So again, focusing on just a piece of the paper, it's about values. And the 4 values that we emphasize in the paper and we're emphasizing today are, as you see there, that it's a patient and family-centered social responsibility and equity paradigm that we're dealing with. And I'll say a little bit more about that in a moment. We're committed to changing outcomes. It's about change. It's about making a difference. Third, the value is that evidence-informed strategy integrates, it must integrate research and knowledge translation. And finally, we come from the position that this is all about relationships. And that when we talk about leadership, it's much more about relationships again than about some kind of hierarchical command and control. And a relational approach to information sharing and decision making is key. Next, please. So the social responsibility paradigm that underlies the conversation then is the notion that everyone should have access to essential services, that the partners define essential services in whatever context you're dealing, that education and training are tied to the needs of the delivery system, that we study issues that most affect the population, again, whether you're talking about a university, medical school, community-based organization, or whatever. And finally, that stakeholders that are engaged together commit to continuous improvement, the idea of learning as you go and making change as you go. Next, please. So the implementation framework for change that we've described in the paper has 6 boxes, and I've alluded already to systems thinking. I've alluded a little bit to values, and we'll come back to that. And now I want to move to innovation research. I'm just going to go around the circle again, just to summarize what you've got in the paper. Innovation research, next slide, please. Innovation research is solution oriented. We posit that it is best conducted, particularly when dealing with communities or community-based organizations, by co-production of knowledge, a participatory action approach. It's certainly the way in which I've engaged with research over the last many years, and Allan and I have done work together with, again, communities and using that engagement approach, the notion that you build knowledge and the knowledge leads to education and action, and that there can be measurable improved outcomes. And that's what innovation research is about. And keep that in your mind, because when you think about the application to what you've done, this will be relevant. Next, please. Again, this idea of shared learning, learning networks are one of the elements around the framework circle. Learning networks, there's a vast literature on networks, but the core notion is that you share the learning across organizations and key players, and you keep it flat. You're not dealing with the hierarchy, you're actually dealing with a network, and that's, again, key. Next, please. Another of the elements around the circle is governance, and governance really is critical to success. You need a shared definition of what collaboration means. Oftentimes people say they're collaborating, but what they really mean is, if we collaborate, I tell you what to do and you do what I tell you, and that's collaboration. And that's a real error in action. And so you need to have a shared definition. You need to know who are the players, a shared understanding of what their roles are, and a commitment to relationships. So it's for the long haul. It's not just come in, come out. You can do damage because you're never going to see people again. The notion here is that if you're dealing with complex systems and they're nonlinear, they go over time, then you've got to be committed to relationships. Next, please. So what are the characteristics of great leaders in complex systems? Next, please. Well, leaders are values driven. Again, they have an understanding of the kinds of things we're talking about. They have integrity. It can be trusted and can build trust. They understand complex systems. They differentiate complex from complicated. We work in lots of complicated systems, but those with moving parts, but they're not the same thing as complex. They facilitate and empower rather than control, continuously evaluate and commit to iterative change. Next, please. Leaders in these situations model openness, risk-taking, and reflection. They're not afraid to make errors. They're not afraid to have other people around them make errors. They build an environment that makes that possible to experiment and learn from our experimentation. They communicate vision, and again, that vision thing is something that is very, very important when we're in our organizations. I think sometimes that's what's missing. We get so caught up in the day-to-day that we forget about the vision. They provide support and advocacy, again, so others can embrace the vision. Patient and persistent. This takes time. This is not a one-shot wonder. It does not take you a couple of weeks or a couple of months. It takes a long time. And leaders have excellent team and communication skills. So if those of you that are learners can take into account some of these things as you look at where you want to go and what you want to continue to learn so that you could be effective in your work in a healthcare system. You want to be this kind of leader. Next, please. And transformational leadership is another key element. We need people who not only come in, again, for the short run, but are there for the long haul, and that are prepared to promote transformation, even though it's uncomfortable and on the one hand, uncertain and so scary. On the other hand, exciting, because we don't know exactly where it's going to come out. And the thing about complex systems are that we can rely on the fact that what we do is going to make change, and we can observe that change. We may not be able to predict exactly what it's going to do, but we know that if we can get things moving, that things will in fact re-equilibrate. It's very stimulating. We want people who are in this kind of situation as leaders to provide inspirational motivation, influence others, and again, encourage risk-taking. And finally, next slide, please. We really need more wizards. So those of you that have the capacity to become wizards, that would be really, really helpful. Next slide. And now we're going to move into some interaction and discussion. I'd like you to think about a difficult decision that you faced. I'd like you to think about what you've done and what you could do from the point of view of systems thinking and values-based leadership. How could you apply those principles to experiences that you've had or current situations that you're facing? And we're going to move to use Padlet, which you'll find in the chat, I believe.
Yep, so I'd like to ask everyone to, I sent it, hang on, my apologies. I sent the link in the chat. So if you click on the chat, everyone will be able to go to Padlet. And I'm going to share screen. So Padlet is like a Google Doc collaborative network where everyone here can post their thoughts. And we're going to work on that platform.
So what I'd like for you to do is, could people put your name in, because I can only see actually Padlet right now on my screen. Right. So if you can put on, when you post, can you post your name and then your the point you want to make about how to solve issues caused by the current systems or in the current healthcare system, issues that you faced or issues that you know about, whether it's the organization of the healthcare system as a whole or subsets. We've worked on the opioid issue, which we're going to talk about later, but you may want to talk about that now, or other issues. And if you've got ideas about what gets in the way, challenges that you faced, but also solutions that you can see by using the kind of approaches that we've talked about.
Mm-hmm. And to post, there's a plus button at the bottom right-hand corner.
Okay, and I'm going to call on people as you go and have you speak to some of the issues. I'll give you a sec to just put some things up. So Malcolm, maybe you'll start off. You've posted the UBC Medical School curriculum complexity. Do you want to just make some comments about that?
The curriculum process of designing a competency system, what are the outcomes, and working backwards towards what you need to learn, what are the milestones, what do you need to learn, and eventually confronted the inevitable problem of scheduling. Likewise, I see that Cheryl Sigarik is on from the nursing school, and have for 4 years had an interprofessional nursing student and medical student session. And our first issue every year is, can we actually coordinate the schedules? And what's interesting is how the pandemic disrupted everything, forced a whole bunch of changes, which may actually now enable more things to happen, because a lot of the scheduling had to do with availability of rooms. And now that everybody's used to learning online more, it's quite possible that that disruption will result in more flexibility and innovation.
So thank you for that. I think that this idea of disruption is key in complex systems. What we know is that if you perturb the system, anything that happens, whether it's small or large, I mean, witness, as you've said, this large disruption of the pandemic, and various things occur. And some things are negative, and some things actually can turn out to be positive. And so we have that interesting phenomenon of disruption. And again, Allan's going to summarize some of this and lead us through some discussion afterwards. Conrad Samsel, can you say something about your post on coordination of care and data sharing?
Sure. Just from what I've seen in the healthcare system, so I'm from Ontario, and the sharing of data between healthcare providers is obviously something that can have a positive impact on the care of patients. And just through speaking, I did speak with one person from Healthcare Excellence Canada, and there's a lot of issues around, or there's a lot of work in the front end around, so encouraging clinics and encouraging, let's say, ministries to share data. And there's also change needs to be also done on the like technological side. So encouraging the implementation of like digital health records and the sharing of that data through standard systems.
So what sort of challenges have you experienced with respect to that kind of sharing of data?
There's a lot of hurdles, I think. Just on top of my mind, I think like privacy laws, everything needs to be considered. There's a lot of perspectives which need to be taken into account. It's a very complex issue. It's not like a simple like flip of the switch and we have like data, we can share all our data between clinics. There's a lot of barriers, I think, involved.
So how do individuals who understand the complexity, but who want to see this outcome of coordination of care by sharing of data, how do you get past some of those barriers, applying some of what we've been talking about?
I think it's important to work with, I think it requires a top-down and a bottom-up approach. It requires like bringing in individuals, different stakeholders to kind of start that change, I think.
Okay. Taylor, you've put up some fundamental issues here: wait time, slow policy, which is the bane of all of our existence. You know, I was a family doctor, and so I learned that things take time, and I have to keep reminding myself of that every single day, because I want policies to change when evidence is obvious, and yet it takes a really long time because one person's view of what sufficient evidence is different from others, of course. Can you say something about your posting?
Yeah, and to go off Conrad's too, I think his point about sharing data and telecommunications and stuff like that for the health systems is so relevant. And I actually have like a really easy example for, I know what it's a lot bigger issue, but even the fact that I think they just developed one, but I was working in a research setting probably like 2 or 3 years ago, and we needed MRIs for patients to look at their scans before admitting them into a study. And the hospitals didn't have a mutual way of uploading MRI scans. So that meant that we would have to get the patients to go to their original hospital, get the CD, mail us the CD. We would have to upload it into our personal Coral system and then wait for a radiologist to review it. So that's just like a really basic example. If we had some sort of sharing system, we would have been able to screen patients way faster.
So again, you each alluded to some logistical issues, which potentially are changeable, but people have to recognize that they're not an insurmountable barrier. They are a barrier, but how do you get around that barrier? And again, applying some of what we've talked about. So what were you able to do, or what do you think you could do, Taylor, with respect to changing that, rather than that laborious thing of people having to download and, you know, I mean, bring it to you physically?
For this one, it maybe is like a more of an innovative tech approach that needs to be taken, like, or maybe a governance issue of just getting to the, like, who regulates it and why can't we create this system? But it's really hard to tell. For some of my other ones, things like accessing healthcare and stuff, I think that has a lot to do with values and how we set up our hospitals and where we locate resources and stuff like that. But I think they are all things that can be changed. And I think implementation is like a really important factor going forward. So
acknowledging at the front end this notion of the values chain, the idea that sometimes when you're dealing with the logistical issues, you can get really down in the weeds. But if you can step back and think about what are the basic values you're operating by, and what are the outcomes you're actually trying to jointly achieve, that sometimes allows a different view of what's possible. Again, one of the simpler ways is some external disruption may change things, but assuming you're stuck, you're going to meetings, you're talking about the same things each time, rather than sticking to the agenda and just talking about, well, exactly how do we send this from A to B? Can you get people to go back and say, what are we actually trying to achieve? And is there another way of achieving it? Is that kind of what you're driving at?
Yeah, exactly. It's like, especially in healthcare, a lot of us have the same goals in mind ultimately. And if I think you're right, like if we can step back and realize that, then we get things solved a lot faster. It's kind of, Dr. Mate was referring to it yesterday too, about how when we all realized there was a pandemic and that we needed solutions to COVID-19 and we need to come up with things, our rate of change all of a sudden was way faster with pushing policies and pulling these task force together, because we had a concentrated effort on something that everybody cared about. So I just think it's true. It's not a limiting like stat, but it's a rate that we can alter if we put attention to it. And I think a lot of that is value.
So the lessons learned from the pandemic that are going to be most interesting, in my view, are in fact these things about how the impossible suddenly became possible. I mean, something as simple, if you will, as providing a reimbursement arrangement for people doing telephone care or virtual care, which had been impossible, was seen as impossible in many provinces around the country. You know, overnight it became possible, and we've seen a restructuring of how care is delivered that clearly is going to remain with us in some manifestation. The question will be, again, how do we use a values-based approach to decide what do we keep in the way of the changes? What do we go back? How do we do it differently? Do we want to go back to what we had before? And again, if you think about it being about relationships, about access, about social responsibility, about sharing learning, all of those principles actually apply. And people sitting around the table who understand those principles can shift the conversation. Damien, you've put up something about screening, vision screening. Do you want to say something about that?
Yes, thank you. I apologize for my camera not being on. I'm having some technical difficulties, but
Okay.
while I was doing a project in the Niagara region, I worked with public health to implement a QI project for the vision screening program. And in the process of doing this QI project, during the stakeholder engagement phase, I ended up speaking with a lot of community members who were involved in this program, public health leaders, as well as the nurses who are part of the program. And I noticed that there were a lot of different perspectives on the value of this policy as it's being implemented, especially in the context of there being multiple qualified providers, right? So public health is able to deliver this screening, primary care physicians are able to deliver this screening, and optometrists are able to deliver this screening. And so I noticed that it became very complex, because some of the questions were, well, who is best to deliver this type of screening? Also based on the negative outcomes of a missed vision defect or issue. The universal approach does have value to it in the sense that we want to get we want to try and get everybody. My understanding of this issue is still not comprehensive. It's a very complex issue, but I noticed that there were a lot of different perspectives and opinions on the universal approach, given that there are all these providers that are capable of providing this screening. So
what do you think is behind that? Beyond the question of universality and so on, why is it that when you have multiple providers, there's sometimes it seems impossible to come up with who should do what?
I'm not completely sure. If I had to kind of speculate, I think there might be some political aspects as well. I know that billing is a factor. I think it also comes down to what services are accessible and nearby the patient, right? Let's say if the optometrist is down the street versus having to go downtown for your primary care physician, if that were the case. So there were a lot of different aspects. I also see Taylor has mentioned siloing. And I do agree with that. You know, these silos and trying to get these providers to communicate with each other on who has been screened.
So those are
Yeah.
really good points. So again, if you're looking at the 6-factor framework, you've got implementation. You're trying to implement a policy. Everybody's agreed it's a good idea to do vision screening, but now what is getting in the way? And you've alluded to some of the issues that relate to the consumer, the person who's receiving the service, or the community's receiving the service. I mean, it obviously matters. If you set up a service that's impossible for people to access, you're going to have a failure of your program, and you'll then blame it on the consumer potentially, but it's actually a failure of the system. You have this very real issue of conflict of interest when we're dealing with multiple kinds of providers. There are political and financial elements, and you have to acknowledge them. You just have to recognize they're there. And then deal with them, because that may be a fundamental flaw in terms of implementing. So a really good example, So how might you intervene if you're the person sitting at the table and who kind of sees the variety of perspectives? Is there a question you could ask or an intervention you could make that you can think of that might change the conversation?
That's a very good question. To this day, I'm not sure if I really know what would, I guess, be the best question to pose.
Anybody else have any thoughts? You can post it. And let me underline. I've purposely said question because my experience has been that when you're stuck, when you're in a situation, it's clear, you can see it's stuck. People are kind of getting more and more locked into their individual positions, moving apart from one another rather than together. Then sometimes asking a question that disrupts the conversation can be helpful. And my experience with learners, by the way, in situations where we've tried to make change that's been, 40 or 50 years, we've been stuck in curriculum in postgraduate medical education or undergraduate. It's sometimes the learner who says, gee, how come if this is so important, there hasn't been a change in 40 years? What is it that's making it impossible for us to go forward? Now, that sounds like a pretty basic question, but actually, because you can come in with that sort of, I'm the naive person here, I'm the newest in the room, you can get away with asking a question that could result in a change in the conversation. I've noticed there's a variety of perspectives being described here, and it seems like we're stuck. How can we get through this, given that what we're trying to do is X, Y, and Z? That's the kind of thing.
I guess the question that's coming to mind now would be like, why is there such a disconnect between the providers and the what's the word I'm looking for? It escapes me right now. I guess I would just say, like, why is there this disconnect between the providers? I think if we could kind of get these providers communicating their own practices as well as public health, maybe there could be a better coordination of how these services are implemented.
Really good point. So an interprofessional approach, the kind of thing Malcolm was referring to earlier, trying to get nursing and medicine together and so on. If you can have this acknowledgement of a shared value of social responsibility, we're all trying to do this thing together. We come we look at it with different lenses. We know we've got baggage. We each have baggage that we bring, but how can we get past the blocks? Because at the end of the day, we're trying to implement this change, right? So good points. Anybody else who wants to post? I know our time is short, so I'm going to turn
someone said in the chat, our Cormier said a few questions. So what are the critical success factors for delivery of this service, regardless of profession who delivers this service? And what do the clients value most about this service? And what are some hopes that we can share about this program?
Terrific. So those are both really important, again, questions to apply when you're stuck. This is all about recognizing, again, you're sitting in the room, in the place where you're now working, you're new in the role, or you're representing an organization, and you realize the conversation's stuck. It's just repeating the things that have been said at the last meeting. And so you want to ask, what are the critical factors here? Those are the kinds of things.
Can I add that one of the things that Don Berwick said is if he had only one opportunity to change, it would be to bring a patient voice in. And because patient voices tend to be gentle disruptors. And
Right. So thanks, Malcolm. Yeah, again, you know, the patient in the room, when we put people who are in the public, who are not health professionals in the room, it does change the conversation. It sometimes makes people really uncomfortable because, you know, you have to use different language and so on. But again, the patient asks questions that may be seen by the health professionals as naive, but they tend to be, they've got a little more room for flex. They'll listen more carefully sometimes, or more openly than they do to other health professionals. So that's another way to you know, if you think about participatory approaches, if you can facilitate bringing in the patient voice when you're trying to figure out how to get past a barrier like the vision screening policy or sharing of data, will that help to open up the conversation differently a bit? Allan, I recognize the time, so although we could go on for, you know, another couple of hours, I think we should probably shift to you if that seems like appropriate timing.
That sounds good. Thank you, Carol. So what I'm going to do is shift to screen share with my slides on it. Give me just a second to do that. And I think you're there now. Are you seeing the slides the right way now?
We're not seeing your slides,
Yeah.
Dr. Best.
You're not seeing them yet.
You're not sharing yet, yeah.
Well, why not? That's interesting. We did a dry run on this before we started.
Well, while you're doing that, I'll just, while you're sorting out putting that up, I'm just gonna note that a very nice note from Cheryl Segaric in the chat that says, patients can identify or name the elephant in the room where the professionals may be reluctant to do so. I think that's absolutely right. Patients can sometimes see the whole elephant or certainly see other parts of the elephant when sometimes, you know, one of the real issues when you have certainly a bunch of doctors in the room, for example, trying to solve a complex problem, they all see it from the point of view of the doctor. And somebody else coming in says, well, wait a minute, I don't see the trunk, I actually see the tail. That's what's getting in my way.
So Judy, let me get you to help me if I can. I've got two screens. I've got the slides ready to go on one of the screens. But when
you're choosing share screen, are you sharing the correct screen?
That's probably a good question. Share screen. Which screen?
Yeah, I might give you a couple desktop options. So if you're using a monitor too.
Oh, there you go. We see it.
There you are.
Perfect. Yeah, we're seeing it.
Okay.
We're set to go.
Yeah.
So, as Carol mentioned up front, we've worked together for at least a couple of decades, I think. And about 15 years ago, we put together a group of like-minded colleagues to really start to build a bridge that would focus not on the more academic kind of research, but on really doing the kind of applied research and work collaboratively with the end user of the research so that we could have better bridges for evidence-based practice. So that's what the InSource Research Group is all about. What I've been hearing so far as I've been listening is, see, I'm seeing the wrong thing.
No, you've got key themes are up there, Allan.
Yes, it is, but you're still seeing the stuff down the side, aren't you?
Don't worry about that. Just deal with the ones on the screen. Oh, there you go. We are.
Okay,
right.
You like it?
Yeah.
Yeah, that worked.
Now it's the main slideshow.
Okay, sorry about this.
No, I did it all this morning and I did the same thing, so don't worry.
Okay, so what I've been hearing is the importance of communication. Malcolm mentioned it right off the top. What we've been finding in our work is that the starting point has to be relationships, not communications. You have to think about what kind of relationships do you need to build across the diverse partners that you're trying to bring to the table, and then designing a communication strategy that works for them. As you know, there's going to be a lot of variation in terms of what kind of communications people actually pay attention to and how to do that effectively. And in a complex system where things are changing all the time, communications is absolutely fundamental, but even more important in some ways is relationships. I started to hear about disruption, recognizing that the system as we have it at the moment is really structured in silos, and the silos don't like to change. They don't move easily. People are familiar with their way of doing things, and they don't really want to try new things. They're comfortable with what they've got. So getting individuals and systems to take the risks, to actually try doing things differently, is pretty fundamental. And again, the relationships that we're building with the communication certainly are going to be a stepping stone towards that, but it won't get you the whole way. What we need in part are the right kind of data to really foster the sorts of changes, sorts of collaboration that we're talking about. So I heard something about the data not being really adequate and hard to get at. So fostering that kind of a data system, building it so that it's meant for sharing, that it's got real-time indicators in there, and most important, that there's the potential for feedback to people. Again, if you know about QI and systems thinking, you know about this kind of thing, but it's rarely done to actually build effective feedback loops.
And if you don't have that, you can't have learning networks.
Nope, you can't. So shared goals and resource platforms. It's not too hard to get people to go through a visioning process and to agree on what they'd like to achieve. The outcomes that the different diverse organizations are looking for are likely to be somewhat different, and somehow you need to take that into account. Perhaps most difficult is that they rarely are going to have the resource platforms that are necessary for this kind of close collaboration, and you may need to build something that's different than what's theirs now. And there's a tendency for most of the partner organizations to want to hold on to power, to want their way of doing things, to think that they can be the best common platform for the network. Not necessarily the best idea. I'll come back to that when I talk about the project that we've been using as an example in just a few moments. One of the things that I think is most difficult about this approach is the fact that there are diverse contexts. People aren't operating in the same kind of place. They don't have similar kinds of cultures, similar kinds of perspectives on things. And that really got in the way, for example, with that visioning process that you talked about, where people were seeing it differently because they lived in different worlds. And what you need for complex systems is to allow the flexibility so that different organizations could do things still in their own way and within the kind of own culture they've created, but nevertheless be working towards these common goals. Politics and priorities. In our work, what we often find is that there's a huge disconnect between the what, which is relatively easy to get people to agree on, and the how. What are the actual processes that you're going to use to put things in place? And that's what I hear in some of the conversations so far this morning, is where things are breaking down, is that there's no common agreement about what's the best way to do things. Everybody's got their own way of doing it, and that getting to the how and how we're going to most effectively work together and achieve our common goals is the tricky part. And then finally, that point you made, Malcolm, about patient voice and general disruption, and that's certainly central to the perspective that Carol talked about up front, that we have to have this patient-oriented approach. And it's all too common to forget about it, and all too common to find difficulty in actually making it a reality. So let me take you through an example of a project that we did recently. We were asked by the province through the Michael Smith Foundation to review the literature on what was happening with the opioid emergency, what kinds of things would be the most effective things for the province to be doing, and how did that correspond to what was working in other jurisdictions. So they asked us to both do a literature review for them and to do a key informant interviews across the world with the different jurisdictions that seem to be doing a better job of it. And I've given you the reference there for where you can read more about this if you want to. The first simple rule that we came up with there was to collaborate, and that's what we were hearing consistently on the literature and from all of the different groups that we talked to. Again, they really highlighted this what versus how. The literature largely talks about what. There's very little in the literature on the how, and that's what we were getting from the key informants. They really wanted to talk about the how of implementation and continuous improvement, to their credit. And it was interesting the extent to which the different jurisdictions had been primarily focused on networking internally to their jurisdiction, but they really saw huge value in learning how to do a better job of learning, getting in touch with other jurisdictions and sharing that learning. And I think we've seen that, for example, with the current COVID situation where everybody's fumbling with it, and it really helps to look to other jurisdictions and what's working for them. The second theme that emerged from our literature review and interviews was the importance of firm foundations. The importance of actually making sure that you're dedicating the resources that are likely to be necessary for the kind of operation that you want to run. At least initially, there's a real tendency to just try to do things off the corner of the people's desk. To BC's credit, it recognized fairly early on that that wasn't going to work. It needed to be identified as an emergency. It needed to have specific resources identified to it. BC went as far as to actually create a separate backbone organization that was standalone and independent of the various partner organizations, so they could really be the coordination body. The leadership really becomes a critical issue at this point, because unless you have leaders who have the power and the positioning in the organization to give the authority, the resources, and the mechanisms for communications, coordination, and support, it's not going to work for them. For the opioid crisis and for problems in general, certainly it's true for the COVID crisis now, that you need to identify what are the best treatments. And it wasn't an obvious answer. And we heard consistently that we aren't currently using the best strategies, the best treatments for this. And we need to do a better job in Canada of identifying what the optimal treatment mix would look like, and then moving towards a continuous improvement strategy within that. Continuity of care. We found, talking to the different partners, that there are a range of different approaches that are going to be different for different populations, and that it's important to have a strategy that has the complexity in mind to take into account the different subpopulations are going to have different kinds of needs. You're going to have the flexibility to tailor the strategy, yet bring it back together with some common indicators and measurement approaches. One of the things that's critical around the continuity of care, of course, is reliable transitions. And certainly for the opioid crisis, we found that there are several very different populations that are having problems with addiction, and providing the appropriate transitions, whether it be people on the downtown east side in Vancouver or people overdosing in their upper class homes because they've gotten addicted through the treatment from their doctor. It's very difficult, and they're going to need different kinds of transitions to carry it forward. Ongoing training we found to be particularly important with the opioid crisis, because it really involved a lot of different disciplines working together in new ways, particularly around the public safety and some of the police operations, for example, first responders, the people who are doing it on the street, and then people who are operating out of the hospitals or whatever. Very different approaches, and they needed to have enough common training and effective coordination so that they could bring those different strengths to bear. feedback loops, fundamental to any complex system. With the opioid crisis in particular, we found that there was really going to be a wide variety of indicators were going to be needed to basically tailor the programs to the different population needs, and that real-time linkage and access would be a significant problem, and it has proved to be. BC CDC has done a better job than most in providing real-time data, and it's something that we can build on, but it's certainly not a magic bullet yet. And then finally, getting at some of the root causes. With the opioid crisis, there was huge resistance, and there continues to be huge resistance, really getting at the fundamental determinants and then starting to move upstream from the poverty, unemployment, racism, housing, criminal justice system, some of those things that were really underlying the problem, and just addressing the actual overdose itself wasn't going to deal with it. There's a need to focus on those kinds of relationships and living conditions, perhaps as a first step, and then move on to some of the other issues later. Those are the critical themes that came out of the literature review and the key informant interviews that we did. What I'd like to do now with the remaining 5 minutes or so is open it up again for discussion. Any questions or thoughts you have, put Carol's and my emails up here, and certainly if you have any thoughts and questions following, we'd be delighted to hear from you. But let me just open it up. What are people thinking about what they're hearing?
Yeah, feel free to just jump in. Most people don't have pictures up, so well, while you're gathering your thoughts, let me again just emphasize that our reason for being here this morning is fundamentally because we believe that you, young leaders, you are the young leaders in training who we hope will be able to achieve more success in making change than our generation has done to date. But the only way in which that's going to occur is if you actually can bring a different viewpoint, a different way of looking at things. And some of what we've been talking about this morning, we think constitutes the sort of interventions that could be done by someone like you sitting at a table, seeing the world in a more complex way and being able to ask those questions that may just get people to move from the what to the how and to give up some of their protection in their silos. Conrad.
I think that the theme of indicators is really important, and like defining how you're going to measure the impact of those interventions. I just thought, yeah, because I'm looking at right now health outcomes and how we can incorporate health outcomes into incentivizing better quality care and more patient-centered care. So that theme of indicators, I think, comes up and is really important.
So that's of course, you know, as a primary care doctor, I can tell you that was one of the most difficult balance points for me, was the fact that so much of what I was interested in changing was going to take a long time, and we needed intermediate indicators to be able to prove points so that we could actually keep doing what we were doing. And so coming up with process indicators, coming up with short term, but keeping an eye on the longer vision and recognizing that whether it's medical school curriculum outcome, you know, changing curriculum and the outcome of that, or whether it's a new screening program, you need to be able to look at the long term as well and not get short circuited. Boy, with the opioid issue, that's certainly an issue for us. I mean, you know, people want immediate change, and this has been such a long time in the growing. It's taking a long time to see some of the long-term changes. Yet we've been able to see some changes in our evaluation of the strategy in BC, some positive directional changes. So you're absolutely right. If you can't measure it, right, you can't tell if you're actually making a difference. And measures may be qualitative as well as quantitative. So other comments or questions? So one of the things, sorry, go ahead. Yep.
Oh, so for the 6 different value-based leadership, like the aspects that you talked about, what was the hardest barrier to implementing these ideas, these values?
Yeah. So the thing about working in a complex system is you can't answer that question because there isn't one. It's an interplay. It depends where you are. It depends on the people around the table, depends on the nature of the relationships. But if I had to pull one thing out, I go back to Allan's point that everything actually rests on relationship. Even the shared values and vision rests on relationships. So if you don't build the relationships and maintain the relationships, then everything else can fall apart. If you have the relationships, even when you get stuck, even when things get really hard and ugly sometimes, you know, if I care about you, you know, Malcolm and I have worked together over many years. If Malcolm asked me something, even if it made me crazy, I'm going to know that I value my relationship with Malcolm and I'm going to stay there in the conversation, even though we might disagree. But if we don't know each other, if what I have is a black box with your name in it and I don't even see your face, it's a lot easier for me to cancel you. So if we want to not cancel, then build those relationships. And again, when you come in as the younger person in the room or the newest one on the team or whatever, you actually have an opportunity to be more open, to be more, apparently naive, but really what it is open to things and to maybe shift the conversation and change the outcome. When you're looking for a job placement, and that's in our abstract, when you're looking for where to work, look for where is it possible for you to have voice and to form relationships.
And I'll answer your question, Judy, slightly differently. Certainly agree with Carol's answer, but from many of the large projects that we've had lately, the greatest problems are around governance, and specifically, how do you get government to take this collaborative approach to things? Governments aren't really built to work collaboratively, and it turns out to be quite a challenge. And again, I think that's a fundamental choice in terms of careers. Do you think that you could do more of what you want to do by working within government, where there is a lot of power and ability to do things, or working a little bit outside the system in some other context that'll give you more freedom to do things? And there's no right answer.
Yeah, couldn't agree more. We need people who are prepared to go into the governance arrangements, work in government. But we need to also support our colleagues who are working in those environments and recognize, you know, that is they are by definition hierarchical and intermittent, you know, with elections every couple of years and so on. So we just need to, again, if you care about the people you're working with, you recognize it may be harder for some of us in our settings than others, but we need everybody, because if we're going to make change, it's not one entity that makes the change. I think we're out of time. I would have loved to have had a longer conversation with you. Hopefully we'll have an opportunity to meet some of you in other settings at another time. But hopefully, again, this will be helpful to you. And as Allan said, if you've got questions or if you just want to be in dialogue about something that you, when you go back to the paper and you read it, if you've got a question or a conversation, please be in touch. We both respond to email.
Thank you so much, Dr. Herbert and Dr. Best. Before we end, we have a little prize draw sessions. So I did a random number generator, and it's for a $25 gift card, and our winner is Damien Henderson. So if you want to send me your email, name, and if you want a $25 gift card to Uber Eats or Amazon in the chat, that would be lovely. And thank you all, the rest of you, for coming today and attending this wonderful session. We had very good engagement, and I hope everyone got to take away something from this session.
Great.
Thank you.
Thanks.
Yeah, thanks. If Dr. Herbert and Dr. Best want to stay on, we can have a little debriefing afterwards. But thank you, everyone else.
Thank you all.